Well, hello, and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today, we'll be discussing brain tumors with one of our favorite doctors, Dr. Alvin Marcovici. Return guest, you've been on our show, I think now this is probably the third time, right?
I think this is fourth.
Fourth time. Wow, great.
Yeah.
Awesome.
Yeah, he's been great.
So, I'm sure it's going to be a great conversation, but before we begin that, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. So let's start with, tell us a little bit about yourself, and just to the audience out here who may have not seen the other 3 or 4 episodes.
I have to thank you for inviting me back.
It's always a pleasure.
It's great.
So I'm a neurosurgeon. I've been in the community. This is the only area I've ever practiced medicine in southeastern Massachusetts.
Nice.
And I was telling Nancy earlier that I never had initially intended to follow the neurosurgery track. My mother was a pulmonologist, a lung doctor, and in college and medical school, I was very interested in immunology. So I had done some research and published a couple of papers in a condition called sarcoid, inflammatory condition of the lung, and I had always imagined myself I was going to be the next great sarcoid expert. And I was offered as part of my medical school rotation, there was a neuro rotation where there were different choices of neurology and neurosurgery rotations, educational opportunities. And I knew the hours would be terrible, but it was only 4 weeks. So
Right.
I decided to do that. And, as I say, my life was changed forever. Once I saw neurosurgery, once I was exposed to it, I couldn't imagine doing anything else.
What did your mom say with the change?
Well, unfortunately, my mom had passed.
I'm sorry.
So she never actually got to see me become a doctor or a...
Oh, that's sad.
But she remains my guiding light and my inspiration.
Oh,
That's great.
that's nice.
So you did this rotation and you fell in love with neurosurgery.
In love with neurosurgery.
Yeah.
My mentor in residency said, a day without seeing the brain is like a day without sunshine.
So, what is it about neurosurgery that you love so much?
I think it's the marriage of three, to immediately dive into brain analogies. It's this right brain, left brain. It's very analytical. You have to be very, you have to be somewhat knowledgeable about the anatomy and the structures and things. But the surgery itself is an art. There's an art. You could be the world's best scientist, the smartest person in the world, and you might be a terrible neurosurgeon. Or you could be very skilled with your hands, but not use the right judgment on how to approach something. So that sort of balance is great. And it's actually surprising how many neurosurgeons like to work with their hands doing other things, either woodworking or cooking, or I've known many neurosurgeons who are actually great artists.
Do you do any, I know this is going to sound like a lame question, but do you do like any dexterity exercises to keep your fingers nimble?
I do not, and I don't think anybody does.
Okay.
That being said, pretty much every neurosurgeon I know does some sort of hobby that utilizes their hands. A lot of neurosurgeons are musicians.
Yeah.
And so that keeps your hands flexible.
Oh, yeah.
Interesting.
Right.
Yeah.
So now with the surgery, well, before we get into that, talk to us a little bit about the topic of the day, just like brain tumors in general.
So brain tumors are, number one, very frightening, as you can imagine.
Of course.
But they're also very vague. I'm sure everybody listening or watching is thinking that, okay, well, how do I know I don't have a brain tumor? And the truth is, the most common complaint is headache. Well, although the most common complaint for people with brain tumors is headache, most people with headache do not have brain tumors.
Right.
Right.
So, there are really no early warning signs. If you had to say something, you would say headache, but that's not very specific. Sometimes people will have things like stroke-like symptoms, and the difference between a stroke is it happens suddenly, and usually with a brain tumor, it's gradual onset. So the same things we look for in stroke: speech problems, vision problems, weakness on one side of the body. Those will be similar in stroke and in brain tumor, with the exception being the timing. And then other non-specific things like nausea, vomiting, visual changes. And again, most people with those problems do not have brain tumors, but once in a rare one they do.
So it sounds like you're diving through a lot of different types of testing before you finally, because that's like the last thing almost that you're looking at, unless there's some other telltale sign. Like if someone's coming in with some of the symptoms that he just said, you're ruling out a lot of other stuff before you're finally thinking,
Well,
maybe it's a brain
like
tumor.
Dr. Marcovici said, in primary care, we see a lot of headache complaints and, things of that nature. And, if I were to work up 1,000 people with headaches,
Oh, right.
I don't think there'd be one with a brain tumor. Maybe a couple thousand, I might pick up one. But I don't know the statistics quite honestly, but I don't see it a lot. But when you do see it, it's of course devastating. So, but I think we're going to talk about treatment today and, what can be done. And there's always, hope depending on what type it is and where it is and how advanced it is. Often there are things that can be done, but yeah, it's not common. I mean, I guess as you've mentioned, you don't want everyone with headaches out there to panic, because it's very rare that we see that headaches are from this. On the other hand, if you have, I think, new onset symptoms that are concerning, like, a new headache, and you're not a headache type person, you should go to your primary care doc to get checked out. You don't have to run to a neurosurgeon, but we can check it out and rule out the bad stuff.
So then, just for the sake of what we've just talked about, are you finally seeing patients when it's like a little advanced?
So, yes and no. Let's back up a little bit and say the vast majority of people who have problems, when people are discovered to have brain tumors, it's usually not the neurosurgeon who diagnoses it.
Right.
Usually primary care doctor.
Right.
Yeah.
And the usual story is someone with persistent headaches or persistent weakness or something. And the usual things are ruled out. So,
Right.
you check the sinuses and you check, certainly you know this much better than I. And when all those things prove negative, and nowadays, things like CAT scans are very available.
Right.
So after a few weeks, a few months, usually someone gets a CAT scan, and then from there, often an MRI if possible, and then the referral comes to me. So by the time I see someone, the diagnosis of brain tumor has already been made.
Right. I mean, the diagnosis is honestly these days pretty easy to make, because we can get CAT scans and MRIs readily, where in the past there was a time where that was not possible.
Absolutely.
It's just knowing who to order those tests on, because there are just so many headache complaints that come into the office, and you don't necessarily need to do a CAT scan or an MRI on every patient that comes in with a headache. So it becomes a bit of a challenge, but making the diagnosis is not necessarily difficult. It's determining who you need to work up that can be a challenge. And then once you find it, of course, establishing the right treatment plan for them.
What's the most common brain tumors that you encounter?
Well, so I see all sorts of people. And a lot of people who come and see me do not even need surgery. So we have to remember that half of people with brain tumors do not have cancer. The most common brain tumors are the meningioma.
See those all the time, actually.
Yeah, so about 10% of us are walking around with meningiomas. It's not even technically a brain tumor, even though it does happen in the head. It's a tumor of the lining of the brain. And it can cause problems, but the vast majority of people, you can just watch them because they grow very, very slow. They're not cancer.
Yeah.
Another common type of brain tumor is a tumor involving the pituitary gland on the underside of the brain.
Okay.
And again, those are very rarely, like meningioma, very rarely cancer, and can also be followed safely. So that's the vast majority of patients that I see that, someone becomes aware of a brain tumor, they come see me, and we watch them.
Yeah, I don't even think of the meningiomas as brain tumors per se. Those are, like you say, fairly common, and very generally you can reassure patients, you can follow them, and I've only had one or two that have had to have those out because they were large enough where they were causing secondary symptoms. But yeah, I think a lot of people just live with those and do fine, and from what I see.
Is part of your job psychological? Because, like, if someone told me I had a brain tumor, I'd be like, oh my God, oh my God.
And people are often panicked.
Yes.
And again,
understandably so.
Absolutely. And that's why when someone has a severe headache, usually the first question to their doctor is, I need an MRI. Right. But it's very appropriate and safe to wait and look for other causes, because even if it turns out to be a meningioma, even if it turns out to be a cancer, God forbid, the delay of a few weeks would not make a difference. The most important thing in brain surgery or in brain tumors is not so much the fact of how aggressive it is. We talked about benign tumors, but benign tumors can be very difficult to treat, can cause a lot of problems. And sometimes a malignant tumor, a cancer, can be removed completely and cured. And so in neurosurgery, we like to say neurosurgery is like real estate, location, location, location. So in some areas of the brain where there's a lot of reserve, like the frontal lobes or the parietal lobes, tumors can actually become quite large before they cause problems. And similarly, those are easier to remove. And then there's some very, if you will, high-priced real estate in the brain where even a tiny tumor, even if it's benign, can cause severe disability.
And then when someone says a brain tumor is inoperable, is that mostly the ones like next to the brainstem? I'm kind of guessing.
So there are many important areas. So the brainstem is a very critical area, and tumors inside or near the brainstem are inoperable. But there are a lot of other critical structures in the brain, like the speech center.
Right.
So you'd never want to take out a tumor and leave someone with no language capacity, unable to speak or to understand. That would be. So knowledge of what those structures are and how close make a lot of tumors inoperable, even though they might be benign.
Sure.
What types of tumors do you usually operate on? Like, what are your kind of the most common types that you usually work with?
So the tumors that usually need surgery are first metastases. So the brain gets a lot of blood supply.
Yeah.
And tumors, once they leave the original organ, whether that be the lung or lung tumor is most common, but there are other tumors that tend to metastasize. Once it leaves, it travels through the bloodstream, and since the brain gets so much blood, the brain is a favorite place for tumors to metastasize to. So taking out metastasis is a very common cause for surgery.
So just to summarize a little bit about what we've spoken about, just so the audience there has a framework to think about. You've got the benign tumors, meningioma, which is really not in the brain, but around the lining of the brain. Right. Some of the other benign tumors, like the pituitary tumors, which can still cause a lot of problems, but they're not cancerous per se, for the most part. And then you've got metastatic disease, which I would think is probably more common than primary brain tumors. That's what I think, but you would know the statistics better.
Yes.
I mean, that's what I tend to see more of in my practice. When I see someone who has a tumor in their brain, it's usually metastatic or often metastatic. And then you have the primary brain tumors, which I think we're going to talk about next. So maybe we can start to talk about that, about what the common ones you would see are.
So primary malignant brain tumors are just about as common as metastases.
Okay.
Oh, I was just going to ask that question.
Very, depends on which study you look, but roughly similar.
Okay, so they're about the same.
Yeah, so if you're looking at brain cancers, you have metastases and then a similar number with primary. And the most common of the primary brain tumors is the glioma, right? The tumor of one of the cell types in the brain. And it's actually not the neurons, because we're born with all the neurons we're ever going to have. So the things that actually send signals in and around the brain, those cells don't divide. And because they don't divide, tumors of those cells are very rare, exceedingly rare. It's the glioma, the glial cells, which support the neurons. That are the cells that are the worker bees, if you will, of the brain. They're the ones that, because they divide, tend to form cancers. So the glioma is the most common primary brain tumor. And of gliomas, unfortunately, the more malignant one is actually more common, the glioblastoma, the grade 4. That is a very difficult to treat, very aggressive brain tumor. And it's affected several people who, are well known, like our former senator.
Kennedy, right?
Do you operate still on those?
You do, because we know that if you can get the vast majority of that tumor out, and then you follow it with other treatment modalities like radiation and chemotherapy, people tend to do much better than just chemotherapy. Even though we know it's not a cure, the treatment with all three modalities, people tend to do much better than just one or two modalities by themselves.
Does that have a very low survival rate? Is that like...
Glioblastoma. Unfortunately, people with glioblastoma are facing very tough diagnosis.
Yeah.
Okay.
It is a tough one.
What are the other common ones that you end up operating on?
Well, there are the other types of gliomas, the lower grade, the grade 3s and the grade 2s. So there's a role for surgery in those. And then there are many other types of glial tumors, the ependymomas, the medulloblastomas, that happen in different sort of areas and different population groups. But the vast majority tend to be those glioblastomas.
So now I'm seeing you just worked me all up, and you're like, well, unfortunately, this is our diagnosis, so off you go. And now I'm walking into your office scared as anything, thinking, oh my God, what's this gentleman going to tell me next? And what do I have to do? Who do you collaborate care with? Like, am I getting chemo first? Like sometimes you hear get chemo, we'll shrink it, and then it will be more manageable to operate on. Is that still kind of true?
So, like with any other cancers, a multidisciplinary approach is always the best.
Okay.
And, I'm almost hesitant to say what's going to happen today, because anybody listening to this podcast a year from now may have different treatment plans. The research institutions are constantly doing work on different cancers, and the treatment protocols change quite often based on the results of the most recent studies.
I'm glad you said that. So for everyone listening, we're recording this on 11/4/2024, the day before Election Day.
Right.
So I'm really glad to hear that, because sometimes people they have so much to deal with and they're scared. So now they can kind of walk into a kind of like there's a team that's going to be working with them to make sure they have the best outcome.
And those are really the people who do best, people who participate in a multidisciplinary approach with oncologists, with radiation, oncology, and surgical specialties. working together because it's a continuum. It's not just, you have surgery and then you have chemotherapy and you're done. We know this is not a disease that's not going to go away. And like any chronic illness, it needs additional treatment and follow-up.
Are there times that you do a biopsy, or would you predominantly do an excision in a primary brain tumor? Meaning if you look at the patient and look at the radiological studies, do you, for the most part, know what you're dealing with? Do you know it's a glioblastoma or et cetera by the radiological appearance? Or do you have to sometimes say, I don't know, I might need to do a biopsy of that?
So you can often tell, but there are always surprises. So you go in with a plan, but, as you're carrying out your plan, it's always good to double check. So that when we get to a tumor with a plan of excising it, there's a way that the pathologists, you talk about multidisciplinary, the pathologists, the expert doctors who look at things under slides, you can send them a piece of the tissue and have them analyze it.
At the time you're doing the surgery.
At the time you're doing the surgery. Now, when you do that, you don't get such a definitive answer because since they're sort of rushed and they have to process the specimen, it's what's called a frozen section.
Yeah.
And, they basically freeze it and stain it and look at it under a microscope. The freezing process sometimes destroys the tissue, so you don't get a really great answer, but you get a ballpark.
Right.
And then later you can get the final result, what's called a final pathology. And that's different by having the tumor, instead of frozen, it's actually embedded in wax. And that actually takes a few days. And it's put in formaldehyde and stained and cut thinly. And that's sometimes the most anxious part for a patient because, they survived the surgery, they feel great, but now they want to know what happened.
Right.
And they're waiting 3, 4, 5 days.
Sure.
Oh, boy.
Answer.
That's crazy.
But at that point, going into the brain is obviously not something you want to do over and over. So you go in and they do a frozen section. You have an idea of what you're dealing with probably already from the appearance, from the radiological appearance, what you're seeing when you're in there. And then you try to do what you can while you're there.
And that's
with the attempt not to have to go back again if you don't need to.
Absolutely right. And so this is where you use the analytical part of your mind. And you take all the information you have from the patient's history and their physical, the radiological findings, and what the pathologist has told you. And you then say, oh, this is a malignant brain tumor. Based on the MRI, I think I can remove this safely. And then you use the right part of your brain, the artistic part, to take out as much as you can without hurting.
Right. And you have to really have an incredible knowledge of how the brain works to know which area you're affecting because, like you say, you don't want to go in there and do something that will affect their ability or the patient's ability to understand or communicate. I mean, there are things that would be devastating, right? So you have to have an incredible knowledge of the brain. And then, I remember doing my dissections back in medical school. I mean, brain tissue itself must be so hard to actually operate on, I'm thinking, because you can't really sew it, right? I mean,
no, you can't. And so it's really, brain tissue has the consistency of like Jell-O.
Right, that's my point.
And so trying to, remove the tumor without injuring normal brain tissue can be challenging. But one of the most challenging things is some of these brain tumors create a large cyst. And once you pop that cyst, it's like operating on a deflated balloon or on a, an empty plastic bag that, it's just all crumpled.
That's so tricky.
So it can be, but we're trained to do it. It can seem daunting, but with the proper training and experience, it becomes quite
I am so glad there's people like you in this world who are like, that's nothing. It's just brain surgery. It's like me taking in groceries. You're just like, oh,
if you had taken the time and spent enough training, I'm sure you could learn to do it too.
I'm sure no one would want to be my patient if I did.
Yeah, my partner used to say, brain surgery can't be that hard because otherwise brain surgeons wouldn't be able to do it.
That's pretty funny.
So, I did a 1-day rotation in surgery, and it was for like a knee operation. How do you get into the brain to actually operate on it?
Well,
Like, are you cutting a little window or something?
The brain and the spinal cord, which neurosurgeons focus on, clearly was, our designer, whoever you believe in, didn't want people in there because they encased the entire central nervous system in bone.
Right.
So the first thing you have to do is remove the bone. So if it's in the brain, you have to remove the skull to get to the brain. And there are different techniques on what part of the skull you are removing. And it's sometimes just the skull removal can be a challenge, especially things at the skull base. So if it's at the top, it's relatively easy to get to. But once you get to the ears or the eyes and below there, there's a lot going on there. There's a lot of different bumps that are going.
Does the brain, like, someone's super overweight, their liver gets really affected. Is the brain kind of the same way, or does it look a little bit kind of the same person to person to person?
It looks very much the same person to person.
Okay. All right.
And there certainly are diseases, like some people may have some atrophy, or some people may have a more fuller brain. But for the vast majority of people, from one brain to the next, they look the same.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
When we're talking about these different types of tumors, is there an age related to, like a prevalent age that's related to certain types of tumors?
Definitely. So when you talk about the gliomas, the most aggressive gliomas, actually, the glioblastoma tends to happen in an older patient population.
Okay.
Younger people do get it, but the vast majority of people with glioma are older.
Okay. So then does it run in families too, some of these types of tumors?
Cancers run in families, and as we do more genetic work, and maybe this is getting into the post-surgery treatment, the genetics of the tumor become very important. And there's certainly people who are at risk for cancers, and genetic testing is becoming more and more capable of detecting that. But nowadays, if you think about the radiation and the chemotherapy, a lot of the treatment depends on specific genetic markers. And in glioblastoma, we were just talking about one of the most aggressive brain tumors. They look for methylation of a certain compound, which wasn't even around 10 years ago.
Right.
And that will actually change the chemotherapy you get. So that's the level of specificity, the tailored approach that people can get today that wasn't available very, very long ago.
Yeah, that is fascinating. I see that more and more, all this really very specific, focused therapy for tumors in general based on, the genetic makeup of potentially the person, but also the tumor itself. It's interesting. It's fascinating.
It is fascinating.
That field has really evolved. Oncology itself has evolved amazingly.
And so, we sit here and we talk about brain tumors, and we're talking about, how daunting and scary a diagnosis is. And we also talked about maybe someone listening to this in the future. But there's a lot of hope. The
Right.
treatments that are available in my career, in 20 years of doing this, the treatments that now exist that were really science fiction years ago.
Things have changed a lot.
Of robotics. So we were talking about how do you tell the difference between healthy brain and the tumor? It can be a very...
Right.
Now there are dyes you can inject into someone that will be absorbed by the tumor, and then you have a special microscope with a filter that can see the dye. And so now you have, remember I talked to you about the collapsing plastic bag. Now you have something that is going to help you identify abnormal cells and to go after that, because we know in brain surgery, the more you get out, the better it is, and the better people do. So that is, again, bordering on science fiction.
How do you keep up with all the new techniques? Like, I'm sure your schedule is busy.
It is, but I think physicians in general continue their education. You know, there's absolutely no way I could have finished my residency training, gone out and do what I do now, whether in spine or in brain surgery. When I came out, when I finished my training, guidance, computer guidance in the brain was just starting. We had the very first models coming out, and I should probably explain computer guidance. So before the early 2000s, a surgeon would just look at a CAT scan or an MRI, take their best guess as what where to go, and make an opening in the skull and hope they find it. And it may seem counterintuitive, but sometimes small tumors were scarier than big tumors because the hardest part was finding them.
Right.
And if you have a tumor the size of a pea that's 2 inches deep, that can be very difficult to find and daunting for a surgeon, because as a surgeon, you know you're going through healthy brain
Right.
to try to get to this pea, wherever it is. And sometimes you don't find it, and it's a lot of sweating and when computer guidance came out, and it was basically, we call it GPS for the brain.
Yeah.
So you have this little, looks like a pencil, you put it on the patient's head, and it tells you exactly right where the tumor is. So you make the cut in the skin, and the cuts both in the skin and in the bone are so much smaller than they used to be, because you don't need to make it any bigger than the tumor, because the guidance will take you exactly there. And then you save the patient from disturbing any normal tissue, because it's taking you exactly to where the tumor is. That was in its infancy when I trained, and now it's routine, as well as genetic testing, as well as radiation. We haven't even touched upon radiosurgery, which has now changed brain tumor treatment.
Yeah, tell us about that if you don't mind.
So as a surgeon, I take offense at the term radiosurgery, and I'll just leave it at that, because when you think of surgery, you think of a cut.
Right.
Radiosurgery is a way to provide a similar result as surgery without any cut. And radio really refers to radiation. So in the past, radiation was given, as we call, whole brain radiation. You know, they took the patient's head and put it in a machine and exposed the entire brain to radiation. And we knew that slowed tumor growth.
But caused a lot of other problems.
Causes a lot of problems. And radiation to the brain causes a lot of cognitive issues and all sorts of issues. Now, any cancer center has a different form of either radiosurgery or something else called IMRT, which is a way of focusing it. So imagine a radiation beam almost like a laser beam. And it travels around the head and focuses on one certain point. And you select that point on a computer. And then the machine travels around the head. And the benefit of that is every other part of the brain gets a small dose. But where all those lines intersect, there becomes a lethal dose and kills the tumor.
So you have a certain amount of energy going from this direction to a point, from this direction from a point. and it's where it meets
Correct.
that causes the most destruction of tissue, which in this case would be abnormal tissue or a tumor.
Exactly. And again, to date myself, when I came out, there was only one type of radiosurgery. It was called Gamma Knife. It looked like a old-fashioned hair dryer, like in the salon with, I forgot how many, something like 100 different sources that focused at one spot.
Right.
And you were limited. The spot couldn't be that big. It couldn't be bigger than an inch because, like anything that you focus, the bigger it is, you're not really focusing it anymore. And so now the edges become sort of blurry, and now you're destroying a lot of normal tissue.
Right.
And also it had to be spherical, like a ball. Nowadays, the machines are so advanced. They have what's called multi-leaf collimators that can have all sorts of weird horseshoe-shaped tumors can be treated, dumbbell tumors, all sorts of oddly shaped things can be treated because these collimators, almost like the iris in a camera, are not just circular. They can make any shape you can dream up. And then as they circle this tumor, they actually change their shape to fit the shape of the tumor. It borders on science fiction.
It's amazing technology.
It is.
But it can't take the place of having to, in many instances, go in there and physically do an operation. This is an adjunct or one option for some patients.
Yep.
But it can't do everything.
So it cannot, but it can do many things that we can't. So, for instance, that critical brain tumor in a part of the brain
that you can't get to,
that's so deep or is in such a critical spot, or this can actually get to those.
Okay.
And then it does it doesn't do as well treating larger tumors, again, because of that focusing thing. And it's certainly much better. And so working hand in hand is really the best for the patient. So an example where we work hand in hand is we were talking how metastases to the brain are very common. Often, if there's a single metastasis, you can choose either surgery or radiosurgery, dependent on the factors for that patient. But sometimes people will come in with multiple metastases, 2, 3, 4. And we know that if we treat them, people can do better. And sometimes one of the metastases is amenable to surgery, and the other 3 may be amenable to radiosurgery.
That's right. Yeah.
And so we'll partner with our colleagues.
Nice.
And say, okay, which one is best treated in which modality? And we'll help in that way. Sometimes the limitations are what radiosurgery can't do is can't relieve pressure. So sometimes if a tumor is big enough that it's pressing on everything around there and making the patient very sick, when you remove it, you remove that pressure. But radiosurgery can't do that. So sometimes we'll take out a tumor that's taking a lot of pressure, and then they'll address the small other leftovers.
When you take out, I have like 3 questions. When you take out a larger tumor, does the brain just automatically shift back to its original position?
Actually, sort of amazing. So sometimes you take out a very large brain tumor that's causing a lot of pressure, and typically after the surgery, we'll do some sort of imaging, CAT scan or MRI. And it's sort of funny that since the brain has been pushed in a certain direction for a certain period of time, it doesn't immediately spring back. And you see this cavity. So you see the brain pushed in one direction, but yet you still see a cavity where the tumor was, and you'd expect it to bounce back in a day or in a... But no, it actually takes a few days, a few weeks for the brain to fill that space.
So then the relief that someone might feel might not be instant. It might be over a little period of time.
If it's making them sick, it will feel much, much better just having that pressure removed.
Are there more tumors that are encapsulated that you see, or are there more tumors that you deal with like the little tendrils?
So the benign brain tumors are encapsulated. The metastases are not really encapsulated, but are quite different from the normal brain tissue. So there's a usually pretty good separation there.
Okay.
And then those gliomas, the primary brain tumors,
Yeah.
those have tentacles. And we know from studies that even if you take out everything you see, and even if you take out a little margin, you could go an inch, 2 inches away from that and still find malignant cells. And so that's why you have to work in conjunction.
So you have to really strike a balance. I mean, you don't want to damage too much normal tissue. So that's, I guess, part of the knowledge base that a good neurosurgeon has to have. I need to take out this abnormal tissue, this tumor, but I have to be cognizant of all the normal tissue that's around it, because you don't want to leave the person with some devastating deficits because you were overly aggressive, let's say, trying to get everything around it out.
Agreed.
Right. That's a challenge.
It's certainly a challenge, but we use the tools around us to help us. We use as I had already talked about, the computer guidance and the imaging aids, which is very helpful. But now we also can monitor different parts of the brain while the patient's asleep.
I wanted to ask you about that because I know with certain brain surgeries, seizure surgeries, let's say, the patient's awake per se, right? So you can see if I go into this area, what might I potentially affect? Oh, you when you do brain surgery, sometimes the patient is
awake.
Is awake?
Yeah. So, wait.
No.
The world has changed. So, when neurosurgery was first becoming safe and common, the only way to know that you weren't hurting someone was to keep them awake. And people find it amazing that you can have surgery while you're awake, but it's possible because only the scalp has pain
fibers. Yeah.
The brain itself has no pain fibers, so you can be absolutely awake and have someone operate on your brain. And if the scalp is numbed up, there's no pain at all associated with the surgery.
So I would need to wear like earplugs so I don't hear you like.
Yes. So usually you put the patient to sleep, and while you do the drilling through the skull, because nobody really wants.
Yeah, no.
I can't even handle the dentist.
I can't either. I know. I'm sitting here like, what do you mean you're awake?
Just that sound and knowing that.
Yeah.
Then once you're through the skull, the patient can wake up, and then. However, doing awake brain surgery has become very rare because of the advances in brain monitoring.
Okay.
And so we can monitor sight, we can monitor hearing, we can monitor
Without the person being awake.
without the person being awake,
Okay.
and we can monitor their motor function. So if you have something very close to the movement center of the brain, right, you wouldn't want to leave someone with a permanent stroke. It's not really a stroke, but similar symptoms where someone can't move one half of their body. You would never want to do that. So you monitor the brain as you do that. The only thing that we cannot monitor today is speech.
Okay.
So if you have something near the speech center, those are the tumors that you would do awake. But
Okay.
everything else, the vision center, the hearing center, all that can be monitored with the patient asleep, which is certainly much more comfortable for the patient.
I would think.
When the patient gets chemo and radiation prior to you operating on them, do you have to wait a certain time? And if you do, like, why? Do those modalities like change the texture of the brain? Or
So chemotherapy affects things that are growing. And one of the things that grows very quickly is our blood cells. So chemotherapy will often make people anemic and will often cause the cells that form blood clots, platelets, to decrease. And so you never want to take someone to surgery, unless you have to, with, anemia or platelets. It's fairly uncommon to get radiation and chemotherapy before surgery. Actually, surgery is the first thing you do because by removing a lot of the tumor, it actually makes those other treatments more effective.
okay, that makes sense. Yes.
So although there are other types of cancers in the rest of the body that often will use chemotherapy and radiation to shrink the tumor first before it's removed, that's rarely used in the brain.
Okay. All right. So one of the other things that you said, about how the brain works and what parts affect certain speech or mobility or what have you. So we don't know everything the brain does, right? Like we only know a small, relatively small percentage. So does that kind of play on your mind a little bit?
We know a lot about the brain.
Okay.
And before surgery, you can often tell the patient what they can expect afterwards.
Okay.
And sometimes surgery is going to create some sort of side effect. And you can prepare the patient saying, we may have to be stuck with, a weak hand, or a weak arm, or a weak leg. But if we can get this all out, it would be worth the risk. You may end up, there are certain areas of the brain that are more apt to cause seizures. And say, well, this may give you problems with seizures, but it's worth the risk in order to remove this.
What are some of the limitations like after surgery? And I know this is so individual, but is the recovery process like a long one, a relatively short one, depending on the tumor, I would imagine?
So it's actually really dependent on the location.
Okay.
And most people are quite surprised on how well they do immediately after surgery.
Nice.
Using modern techniques and the monitoring systems that we have now, patients are often in the hospital a day or two
Really?
after surgery. And, one of the most gratifying things to see is the day after surgery is seeing how patients are just surprised at how good they feel.
Nice.
They just went through surgery and they're doing well and they feel fine. And, after a day or two in the hospital, they feel well, especially if it's something that's accessible and doesn't cause arm or leg weakness.
What are your like top recommendations like after you're operating on someone? It's like, make sure you don't get on a bike tomorrow. We don't want you to fall and hit your head.
So once everything is said and done, when the skull is replaced, it's replaced very securely, so it's not like they have to wear a helmet or anything like that.
Okay.
Patients are usually instructed to perform all their regular activities. Of course, nothing strenuous.
Right.
Don't go out and buy a new house. Don't take out a second mortgage.
Right.
But as far as routine activities, they can return to those right away.
Nice.
And then patients usually convalesce for a couple of weeks, and then we work with our oncology and radiation colleagues to make sure that they get the next appropriate step in their treatment.
How do you get the skull back where it's securely in place? Because like any bone, it has to heal and it takes weeks.
Yep, but we use plates the same way an orthopedist might use plates to secure a broken bone. We use similar plates to secure the skull.
Okay.
And as soon as those plates are secure, it's as strong as the original.
That's good.
Are they plates that you can have a future MRI with? They're not like...
Yeah, I mean, that's critical.
Yeah, right.
Well, the good news is we got the tumor out, but we'll never know because we can never do another MRI. So
Right.
nowadays, there's so many things that are MRI compatible.
Right.
Pacemakers and stimulators.
Sure.
All those things that used to say never again, never.
Right,
Now,
right.
again, technology has
changed.
certainly the plates that are used in the skull are MRI compatible without any problems, much artifact. Again, one of the amazing advances in technology.
Is there a time where, is there a time limit when you're working with the brain? Can you only operate on the brain for so long? Or it's just you have to do what you have to do and it takes as long as...
There are some surgeries. I tend not to be a specialist in this, but I've participated and I know surgeons who will do 24-hour surgery.
Oh my God.
If a surgery, and I've heard of this before too, if it takes that long, you must have different surgeons that come in. I mean, I don't know how you can't operate for 24 hours.
Yeah, yes. So usually you'll have different surgeons who come in, but sometimes it's just one surgeon who is working at a very difficult location for an extended period of time.
Wow.
And people, I do plenty of long surgeries, both in the brain and mostly in the spine. And people ask me how you do it. It's actually very interesting. You do not feel the time go by.
No.
You're just so focused on the task at hand that you don't realize the time passing.
That would be super difficult for me to have another surgeon like relieve me and then like coming back in like 8 hours later or something. It's like a chef like making a very complicated dish. I mean, that's very simplistic, but you just like.
But the other surgeons
you want to
do
do
the
it.
same thing. So it wouldn't be like two neurosurgeons,
Yeah.
doing one shift and the other doing another shift. It would be more like a neurosurgeon working with a ENT surgeon. Working.
Okay, that makes sense.
Like behind the ear,
Right.
or something.
Right.
So quite often we'll work with those other colleagues.
Oh.
Yeah, I can't imagine doing a 24-hour operation.
Oh my God, I can't either. Like just standing. Like, does your back hurt after these surgeries?
Standing is very hard. The good news about neurosurgery is quite often you do it sitting.
Nice.
Oh, that's good.
It's usually done sitting.
That's good.
So, and we have chairs with armrests and things like that to prevent.
Is there robotic surgery that's used in the brain? I know in the spine it's used, but
not yet.
Really?
But you never know. I mean, again, anybody listening next year says he's wrong.
This may change. Right?
This may change.
I'm sure someone's looking at this right now.
The robotic technology,
It's amazing.
absolutely amazing. Absolutely.
It really is.
Now, is there anything people can do for optimal brain health, I guess, like preventative, or it's just like,
Watch our podcast.
oh, is that
That's what you
is
have to
that what
do.
it's gonna be?
Watch our
Okay.
podcast.
All right. Thank you. I like it.
There are a lot of things to maintain good health. That being said, brain cancers are just these things that just
Yeah, they do.
We just bust down the wall.
Yeah, exactly. So I wish there was some treatment that would say,
There's not really a rime or reason with a lot of these. No.
you can have very healthy people and very ill people. And of course, we do have to remember that a large number of brain tumors are metastases,
Mm-hmm.
the same things that prevent cancers. So refraining from smoking and tobacco use,
Exercise regularly, eat healthy.
and eat healthy.
Yeah, all that.
Things that prevent colon cancer
Right.
and lung cancer and breast cancer. Women, make sure you get regular checks and get your mammograms, because those,
Yeah.
although the primary brain tumors, there's not much you can do about, but we certainly could.
As far as prevention, you mean?
Prevent.
Yeah, right.
Other than being a little smaller, what's different with the pediatric brain as compared to the adult brain? And what's your limit with age?
Well, so I don't do pediatric brain surgery. That's just that's a podcast for another day. There are special pediatric neurosurgeons who train on pediatric brain tumors, and there's another field, and that's another field that has just changed dramatically over, because we talk about those other treatment modalities. One thing you almost never want to do to a pediatric brain is radiate it. We found out early in the treatment of brain tumors and pediatric brain tumors that radiation to the growing brain is just disastrous. So we do everything possible to avoid that. That being said, kids, just like in the rest of their body, tend to have totally different type of brain tumors than adults. So they don't get the glioblastomas.
Yep.
They get different tumors called medulloblastomas or ependymomas, which have their own different treatment. And that's a specialty in itself.
Fascinating.
Oh my gosh. I'm just so glad there's people like you that do all this stuff, because
Absolutely.
I'm telling you.
Is there anything that you'd like to leave the audience with as far as a message or a summary statement?
I think the summary statement is, if you have a headache, take some Tylenol and lie down. It's very unlikely for it to be a brain tumor.
Yeah, I agree.
If it's really severe and bothers you, go see your primary care doctor, and most likely is sinusitis or something like that. If you are one of those individuals with brain cancer, go to a center that has a multidisciplinary collaboration between surgeons and oncologists and radiation specialists to make sure you get that whole center care. And the other thing is, don't give up hope. New advances are coming out every day. And I don't exaggerate. there are amazing scientists out there who work every day on finding new treatments and cures. So there's always something right around the corner.
That's great. That's great. Because, it's one of these things that a lot of times people, when they have this diagnosis, it can be easy, I would think, to lose hope because it's such a devastating diagnosis to receive. But there are really new advances in medicine all the time, and it is remarkable. But, what I will also say, just to kind of support what you're saying, if you're out there and you have a headache or whatever that symptom may be, don't jump to the conclusion that you have something horrible. More than not, you have something very benign. But that being said, go to your primary care doctor. They can figure it out for you. And then if you, by chance, have something that is, more serious, we have, fortunately, great doctors like Dr. Marcovici who can help you out. So we really thank you for coming on to the show. It's always a pleasure to have you here.
The pleasure's all mine.
Yeah, we always learn so much with you.
I know.
Really, it's great. How do they contact you? Most likely it would be through their primary, but if someone did want to contact you directly.
Now, our practices are affiliated with Brown University Health, and my location is in southeastern Massachusetts. You can reach us through Hawthorne Medical Associates at 508-996-3991.
Great.
Nice.
Great. Excellent. Thank you.
Thank you.
Well, I want to thank everyone out there for listening to our show. This was a really great show. I really found it interesting. If you would like to become a sponsor, please contact us at 774-319-4230. Special thanks to my good friend Ron Gamache for our intro music. Primacure, your trusted medical providers in southeastern New England, in the BioSkills of the Northeast for producing our show, and available to produce your show by calling 774-301-8811. We want to thank Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And of course, Dr. Marcovici, thank you so much for being on the show and educating us as you consistently do every time you come on. We appreciate it.
Pleasure.
Thank you.
Take care, everyone. Have a great rest of the day, and we'll see you again for the next show.
Bye now.